Welcome everyone to today's webinar. I'm Heather Punke, Managing Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have a time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. We have a wonderful panel for today's webinar. Our panel includes Nancy Lagear, Chief Executive Officer of Novia Strategies, Stephen Goldstein, Chief Executive Officer of Strong Memorial Hospital, Shelley Hunter, Chief Financial Officer of Mercy Southwest Missouri and Kansas, and Dr. Patrice Weiss, Chief Medical Officer of Carilion Clinic and Virginia Tech Carilion School of Medicine. I'll now turn the floor over to Donna Hopkins, Vice President of Novia Strategies.
Thank you, Heather. I'd like to begin our discussion today by orienting us to what we mean by clinical variation. Clinical variation, by definition, is the varying practices and services that permeate healthcare delivery today. Reducing clinical variation means creating uniform clinical guidelines and order sets, reducing tests and procedures, eliminating care gaps, and delivering true interdisciplinary care. In other words, reducing clinical variation means delivering the right care in the right venue, at the right time, and for the right cost. So why this focus on clinical variation? Now is the time to transform care in order to decrease the cost of healthcare. Spending continues to accelerate as a percentage of the gross national spend. Per the IHI, the U.S. healthcare system is the most costly in the world, accounting for 17% of the gross domestic product, and with estimates that percentage will grow to nearly 20% by 2020. Simultaneously, we're experiencing quality of care issues, profitability challenges, mergers and acquisitions, unprecedented talent loss, and new performance metrics. CMS is pressing hard to tie Medicare payments to value, and it is on track to meet their target of 50% value-based payments by 2018. To achieve this, CMS is trying a number of initiatives to shift from volume to value. Shared savings via accountability care organizations, bundled payment initiatives such as BPCI, CJR, and now cardiology bundles, the Impact Act, and MACRA. All these combined, and the fact that private payers are also shifting payment models to value, create a burning platform to reduce variation. Let's take a closer look at a few of these CMS initiatives. Medicare spending per beneficiary, part of the Impact Act, is a new metric spanning the healthcare continuum. It further divides the need to reduce costs and clinical variation across the full continuum of care, from pre-hospitalization into the acute environment and after discharge to post-acute. MACRA, the Medicare Access and CHIP Reauthorization Act of 2015, is a lightning rod to provider practices, forcing collaboration to further enhance quality and continuous improvement efforts or suffer penalties. And throughout this shift from volume to value, we see increasing recognition of the need to focus on patient safety. Newly published research from Johns Hopkins Medicine puts medical errors as the third leading cause of death in the United States. Indeed, the imperative to improve safety and quality was top of mind at this year's ACHE conference. Many presenters spoke about strategies to develop physician leaders, reduce clinically unnecessary tests and procedures, and redesign care processes. In other words, reduce clinical variation. These statistics from various experts mean decisive action is imperative. 87% of community hospitals anticipate declining to negative profitability. Average Medicare payments are reduced 0.61% per patient stay, and commercial payers are following closely on CMS's heels with regard to reimbursement rates and quality penalties. For safe and effective care and to achieve fiscal responsibility, we need to successfully transition from volume to value. To do so, we must eliminate waste and reduce clinical variation as quickly, effectively, and sustainably as possible. To quote Ronald Reagan, leaders begin to lead when they see the light or feel the heat. Now that the heat is building, let's turn to our panel to answer some of the top questions we've heard from C-level executives. Panelists, let's begin. take a closer look at what drives an organization to embark on clinical variation. Stephen, what was the aha moment when you realized you needed to address clinical variation?
Good afternoon. Well, it was not really a moment, but a process where you could see the shifting from value-based reimbursement to from volume-based reimbursement, to value-based care across all payers. When you have commercial insurers and Medicare programs, Medicaid and private self-insured employers move away from fee-for-service, you realize that something needs to change in the way we deliver care and in the way we manage our patients' health. I'll just start going down each of them quickly. In Medicaid, our hospitals have a collective budget of about $2.6 billion. 19% of the revenue is Medicaid. New York State is one of the 8 district states, which means that in 4 years, all Medicaid payments will be capitated, and payment will be based on calculation that is 25% fewer hospital admissions and ER visits than we have today. While we are being paid for projects to help achieve this goal for the moment, the overall goals and consequences of this program are really daunting and require a much more progressive approach to taking care of this patient population. With regards to commercial insurance, about 40% of the total of the $2.6 billion, here we really have an evolution to risk-based contracts. We cover approximately 200,000 lives in our primary care network. To manage risk, we have to form new organizations, one that's called the Accountable Health Partners, which is currently comprised of 2,000 physicians and 6 hospitals. We've actually instituted a governance structure for employed private physicians, full-time faculty, and community and university-owned hospitals, acquired analytics for participating physicians in hospitals, established case management and other assistance programs, all with a view to manage approximately $1 billion worth of contracts with an ever-increasing risk component. We're in the 3rd year of that effort. In Medicare, which is about 38% of the total revenue of our system, we have a potential of, by 2018, being about 50% of our payment by value. Here we really had to cut our teeth on multiple bundles in medicine and surgery, have created a structure to manage them that I'll describe later, and currently evaluating participation in ACOs and Medicare Advantage plans to increase our focus in the area. In private self-insurance employers, we are the insurance plan, in our case for the University of Rochester employees and their families, and this currently comprises 42,000 individuals who are at risk, who the university is at risk for the results achieved. So as our risk grows, a sense of urgency and required investment in care delivery redesign really increased with it. We project that in the next couple of years, about 1/3 of all of our revenues within our network will be tied to some form of value-based care, which means that there's a lot at stake and much needed investment in population health and reduction in clinical variation. It's really safe to say that the success that we have in managing risk has a direct impact on our ability as a medical center to achieve our core missions in the provision of clinical service, education, and research.
Thank you, Stephen. I could see your aha moment was quite significant with the risk adjustments that you all have to make in your system. Dr. Weiss, what was the aha moment for you all?
Well, I actually did have a sort of an aha moment that is really sort of specific to one example. And it would date back to before I was the chief medical officer and I was the chair of the Department of Obstetrics and Gynecology. And quick background, Carilion Clinic is a 7-hospital system, very wide geographic area. And at 2 of those hospitals we were, and we still continue to do obstetrics at 2 of the hospitals. And one of the large pushes that came out from the American College of Obstetrician and Gynecologists, and is one of the perinatal key measures, was and still is elective deliveries and elective inductions before 39 weeks. And we were at our Roanoke-based hospital, where we do a little over 3,000 deliveries a year. We were one of the earliest adopters of no elective early inductions or deliveries, did a lot of work. We are an open hospital system, so we have both employed physicians and private physicians, and quickly became, at our sort of flagship larger hospital, one of the lowest elective induction delivery and rates in the country. We similarly had this on our scorecard of engaging physicians as part of our Tier 1 bonus on hospital performance and system performance. So we just had paid out our bonuses, and we're bragging about our way less than 1% elective induction, only to find out that we received a letter from the state of Virginia informing us that our second hospital doing deliveries had a 17% elective induction and delivery rate. So it indeed was an aha moment. It was probably more than an aha moment, but very eye-opening. And we can do all that we want as we try to reduce clinical variation, implement protocols, standardization. But we have to really know our hospital systems, know our practitioners. In this case, certainly those physicians that we employed were very well aligned in not doing elective deliveries, as was the unit. However, our non-employed private physicians were not adhering. And, certainly a statistic that we did not want. So I think you can have all the great processes in place, but my aha moment was to recognize, know my own system, know my own practitioners, know what goes on at all the different sites, because just the protocols and the policies and the standardizations alone are not enough, but there needs to be a lot of footwork that goes along with it.
Great insight, keeping all those balls moving. The heat many healthcare leaders are feeling is financial. Shelley, what is the connection between clinical variation and an organization's financial performance?
Well, actually, as Dr. Weiss just said, when you have to know your own system, because if you have wide variation, you have, first of all, less predictability in your financials. And so the lack of being able to predict your financial outcomes leads to less operational performance. The first way that you can connect financial performance with an organization's clinical variation starts with the clinical pathways or care paths. We know that we have proven quality metrics and outcomes when we have standardization of care paths that are led by physicians, they're quality tested. You end up with a better quality outcome for your patients, which results in less readmission rates, less complications and comorbidities, and less episodes of care. And that, in turn, translates into, if you have risk-based contracts or you're an affordable care, accountable care organization or value-based, or you have any type of wellness contract, you're going to end up with better reimbursement because you've kept patients well and out of the hospital and clearly more expensive care. The other way that you'll see that is in your purchasing variation. So if you have standardized care, you have less utilization of testing, medications, labs. You know that your standard protocols and what they're going to be, and you can actually predict the cost of care. When you have erratic utilization, then you end up with more costs and more testing that's not necessary for the patient and also very expensive for your healthcare system. And you also have purchasing power in bulk purchasing, as in sutures and gloves and things like that, if you have less variation in your actual practicing patterns. So I think several ways you're going to see a difference in your clinical variation. You're also going to have higher patient satisfaction scores, which we are reimbursed on through Medicare on value-based purchasing. We'll see less quality variation, first of all, so you'll have better outcomes, less readmissions. We will see better patient satisfaction, so also return customers or return patients for those that have choice. And then again, you'll have predictability in your financial systems, and you'll be able to track your costs and improvements throughout the system when you have actual standardized care and standardized processes.
Thank you very much. We all know that financial benefits are one side of the equation, and you've already addressed some of the quality. Nancy, in your consulting business, what other outcomes do you see Novia clients achieve from successfully addressing clinical variation in regards to quality and patient experience as well? Go ahead.
Shelley just gave a great overview of the work, and I think the quality is such an important part of the work. The quality improvements that we see when we address clinical variations are in a host of areas, such as the reduced readmissions that she mentioned, improved pain management, reducing infections, but we also see that improved patient satisfaction as patients and families are more informed about what to expect and they get home earlier. So it might help if I could describe just a few of the outcomes and how we think they can be achieved. When we work with our clients to reduce that clinical variation, we bring key physicians, clinicians, and operational experts together to determine the best care for a patient group or across a group of patients. And we use risk-adjusted analytics in order to identify that best practice at the hospital. But as was stated earlier, it's important that it's at each individual hospital because there's a lot of variation even in systems between hospitals. We share the best demonstrated practice from the literature as well as with our clients that we've seen across an organization or other across the country. But then we map the care processes in order to identify gaps in care along with the data. Hospital physicians and staff then define what that care should be delivered when, where, and by whom, and they define what care should not be provided because it's duplicative or unnecessary care. An example of that is that we worked at a hospital that had an event and so implemented a policy in regard to that where PT referrals were done on all patients prior to discharge or to evaluate that patient if they were at fall risk. Well, this was adding about a half a day length of stay as well as additional cost. So the team decided that nursing should do the fall risk as a part of the nursing care, and that reduced the length of stay as well as the PT hours needed for the overtime in the registry. But what it also did was it improved the quality because there was much more responsiveness to the patient by nursing and integrating that into their care instead of the patients being frustrated about waiting around for that. Another example is that most of you will relate to this one, and that is that the patient having a total knee surgery. When we're looking at the risk-adjusted analytics that are shared with the physicians during the surgery, they then decide what information they're going to use to improve their personal practice as they deem appropriate. And then the team uses this practice information, the physicians, the nurses, to outline the care that they want for the patient. But that's the clinical care as well as how to integrate core measures and or other quality indicators that will help ensure the quality of care. They develop the criteria for which patients, for instance, may say have the patient strengthen their muscles prior to surgery through PT in order to speed recovery, or develop order sets for post-op care, including items such as the antibiotic of choice, or how to make sure that you're managing patients' pain, or post-surgical progressive mobility plans, etc. All those things improve care and improve the patient quality. Last, in addition, daily milestones for the patient to meet are often identified along with the expected day of discharge. And these improvements result in more effective plans of care, better interdisciplinary communication and handoffs, which we have seen in the research improves care, and fewer delays in getting the patient up and moving and progressing home. Most importantly, the changes really do ensure that the patient receives the right care, not too much, not too little, at the right time, both at the right day and even sometimes getting down to the fact that we need to make sure the lab is back by 8 o'clock in the morning, and in the right setting, allowing them to go home more quickly with appropriate home and or outpatient support.
Thank you, Nancy. Dr. Weiss, do you want to contribute any thoughts there?
I guess I'll just, very thorough, and just maybe add a piece as it relates to the patient satisfaction piece. And as I mentioned before, we are a 7-hospital system, and I love Nancy's point about not only can there be variations within a system, but there can be variations within a hospital from floor to floor. So we work very hard to try to ensure that every patient has the same experience, no matter what floor they're on or what hospital they might be in. And again, is theme of this webinar, really try to do as much standardization as we can across all of our hospitals. For example, with our catheter protocols and even our check-in processes for our patients, which at times can be somewhat burdensome for patients. The other is really the handling. I'll give a specific example of operating room specimens. Unfortunately, we, like other hospitals across the country, have had an incident where a specimen was lost, and that is a huge patient dissatisfier. It affects the follow-up of care, affects management diagnoses, and when we looked at that, well, there was a variation in how OR products or OR specimens were handled at certain times of the day. Was there a particular quote-unquote runner? How are they processed? How are our operating rooms staffed? So we've really, focused more on that patient satisfaction piece, because certainly that would be a huge patient satisfaction. The other piece that we stepped back and asked ourselves is, how can we have one ICU that has not had a CAUTI, catheter-associated urinary tract infection, in 3 years, but we have other units that do not come close to that? And, sure enough, as you look into it, it has to do with some of the variation of the placement of the catheter, who receives catheters, does everybody receive a certain catheter? So we've really tried to standardize, and I think the additional theme is, do not too much, not too little, but just do the right amount of what a patient may need, and then always explain to the patient why we're doing what we're doing.
Great answer. To achieve all of these, quality benefits and financial benefits is a lot of work. It's immense work. Stephen, how should an organization structurally approach clinical variation?
Well, I think, Dr. Weiss raised an enormously important point in her opening comments about transparency of data, people working together. And in our case, we're a 6-hospital system. Our university hospital is roughly 900 beds. We have about 1,300 beds all total, and we're actually in multiple cities. So the question was, how do you bring everybody together around this? And as I mentioned, we chose to do it in what's called Accountable Health Partners. 2,000 physicians, 1,200 of them faculty, 800 private physicians, 6 hospitals, all working around how to be successful in value, how to manage contracts. But I think it's important to recognize that there are really multiple opportunities and ways to address clinical variations within any healthcare organization, and not all clinical variations are unwarranted. Reducing unwarranted clinical variation activities with us really involved around bundled payments, care management protocols, utilization patterns, monitoring, a lot of out-of-network referral monitoring, primary care physician incentive programs to really achieve process standards, and clinical quality dashboards for clinical departments, just to really name a few. And I would reference under bundled care some of our major joint replacement. As I mentioned, we did both medicine and surgery bundles. And every clinical variation project has had to start with the data and the ability to identify variations and the reasons for it. As we analyzed our data from CMS on major joint replacement bundles for 90 days, it was evident that most of our variations in both cost and quality came from variations in utilization of skilled nursing facilities. And we really had to work with a number of skilled nursing facilities to really get to achieve optimum results. Now, in your question, you mentioned that it takes immense work. We find that beyond the immense amount of work, it also takes a village. To address clinical variation, we had to form project teams that included members from all parts of the organization that had anything to do with the process and the patient's clinical pathways. Orthopedic surgeons, hospitalists, primary care providers, case managers, financial experts, data analysts, social workers, home care nurses, and nursing home partners all were incredibly important. And we had to meet on a regular basis to come up with a plan that really addressed the clinical variations in quality of care, clinical outcome, cost, and patient satisfaction. Our clinical pathways to reduce variations had to be both on an inpatient as well as post-acute phase. We generated dashboards on a regular basis to review with the care teams and understand what was working well and where we had additional opportunities. And we also had to be able to track patients over time and throughout the continuum of care. So we had to invest in IT systems and processes that really enabled us to do that. We had to assign care navigators whose primary responsibility was to follow the patient, coordinate services, transitions, and so on between hospitals and all of the other patient care providers, specialty offices, home care, et cetera. Now, as part of this initiative, we managed better patient care expectations. We focused on delivering care in a better setting for the patient and could then really benefit from that. We provided all patients with pre-surgical home visits to improve discharge and rehab planning, sending patients home with appropriate level of home care, really provided treatment in an environment where they live and function. This actually resulted in a shift from 74% of our patients going to SNF rehab at baseline to 74% of our patients really going home after implementation of our program. That saved over $2 million. The overall increase, overall impact on our joint replacement was really improvements in quality, increase in patient satisfaction, reduction in overall cost, and was really a team and a group effort.
Thank you, Stephen. You touched briefly on the physician structure piece of it. As drivers of healthcare spending and utilization, physician leaders play an essential role in reducing clinical variation. The right physician leaders cultivating collaboration and process improvements with their peers and clinical teams and partnering with hospital administration to move strategy forward. Dr. Weiss, how did you effectively partner with physicians to reduce clinical variation?
Well, as you said in your statements, it's absolutely key that the physicians are on board and they are engaged. And at Carilion Clinic, we are a physician-led organization. We're very distinct when we talk about that. And we're very clear to say that we're not 7 hospitals that employ physicians, but we're a group of physicians and providers who do some of our work in the hospitals. I think the first task is you really have to go way upstream, and you first have to identify who are your right physician leaders, and particularly in this aspect, who are your right physician administrative leaders. We often will tend to think that the best physician leader is the person who is the busiest, who produces the most RVUs, who is the most popular, but the clinical and surgical skill sets do not always transcend 100% into who would be the best administrative leader, or in this case, the best person to rally the troops. One of the first things that we do, and like I said, we do go upstream, is to really try to identify who are our right physician leaders. And we tap into our chairs for that, but we don't leave it to chance. We have a pretty well developed, and we take it very seriously, what we call a physician leadership academy. We specifically target that to either up-and-coming physician leaders or our section chiefs. Being physician-led, we just can't have leadership at the chair level and then have a huge voltage drop. We have to have leadership at both the chair level, at the chief level, and really try to instill in every physician that in one way or another, you are a leader. We also have physicians on all of our committees, and they often chair or co-chair. So, for example, our quality, our overall Carilion Clinic Quality Committee, and then some of the sub-quality committees are either chaired or co-chaired by physicians. Our materials management and purchasing and our OR supplies, we have physicians very actively engaged and co-chairing that committee for the purchasing of products, for the trial of new products, for when we make a decision to switch from one product to another product, and why are we really doing that. We rely heavily on something that we call the Board of Governors at Carilion Clinic, which currently has about 18 voting members, 12 of whom are physicians, made up of our chairs and other senior physician leaders. Our medical executive committee is made up of chairs. And a real live example is when the go live and we really rolled out ICD-9, our real leaders and champions of ICD-9 were our physicians. Yes, we had administrative folks and coding folks and assistants, but that really was led at each department level and in the practice level by champion physicians. The other example that I would give is as far as the physician leadership and reducing clinical variation. This actually came from within the Department of Orthopedics and then combining up with neurosurgery, but looking at the number of devices or apparatus, or as I would like to say, gadgets, where we may have been greater than 10 certain devices for an orthopedic procedure. Certainly they're having lots of clinical or surgical variation, even very taxing on the support staff in the operating room. And those folks came together and narrowed down to, we were going to use 3, maybe 4 of a certain device. Everyone got trained on it. We reduced the variation. The physicians led the contracting and negotiation with the companies. And, over a 5 to 6 year period, we saved over $10 million. And maybe that wasn't exactly our first goal. Our first goal was to reduce clinical variation, but what came along with that through the physician leadership was a tremendous financial saving to the organization as well, and an increased comfort level by all folks involved in those procedures. So we really, we engage our physicians from the beginning, but I would emphasize again that one must really be able to determine who, it's a whole different skill set for administrative leadership, champion leadership, which is different than clinical or surgical leadership.
I couldn't agree more. Shelley, what are your thoughts on this subject of physician engagement?
Thank you. Just to briefly add on to what Dr. Weiss said without overlapping any of her comments, we have both, small ways to engage physicians and bigger picture ways. We have, first of all, in Mercy, we are a big system, probably around 38 hospitals, and we have specialty councils that combine physicians from throughout the system to get together to talk about things in their specialty to help develop and refine the clinical pathway. So that's one way we engage them. At the local level, even from my perspective as a financial leader, we do it through the building of relationships and transparency of data. The one beauty of a physician from my financial perspective is that they are scientists. So if I show them data, they're always very interested, and I ask for their input. This is what I'm seeing in the data. I'm seeing this variation. It's either this cost or this outcome. Can you help me understand it from a clinical perspective? And just engaging them in the process, continue to show them benchmarks, to show outcomes, and again, engaging them with each other. We also in Mercy have a dyad structure, so we always have not only we have a physician president along with our administrative president throughout the system, and I think having that physician-led organization and physicians in leadership, as Dr. Weiss said, is imperative to continuing physician engagement, and then keeping those relationships alive at every level.
You mentioned data. Nancy, how important are risk-adjusted analytics in successfully engaging physicians in reducing variation?
Well, as Shelley just referenced, physicians are scientists and data is all important to them. Risk-adjusted data in our minds does 4 things. First, if you have valid risk-adjusted data, it takes the issue of my patients are sicker either off the table, or it substantially reduces the argument and opens physicians' minds to truly review the data. Second, once they are willing to look at the data and consider the possibilities, we find that the data will point to the improvement opportunities for them to delve into. Third, we know that physicians really want to do the best they can for their patients. So risk-adjusted data and clinical redesign efforts help them achieve this. When physicians look at solid data and they don't feel that they're being told what to do, but rather they're being supported with data analytics, we find that they very quickly use the information to improve the care that they can provide for the patients. Let me share some things that we've seen in the data and what has been a cause of action for physicians, which will probably help with this understanding. And if your data will point to these types of things, then you probably have good risk-adjusted data to use. So for instance, gaps in care where no orders are written for a patient from Friday until Monday when a physician's partner is covering for them. Maybe they could have been discharged over the weekend. Another example is a bariatric surgery pack being used by one general surgeon, none of the others, for all 70 of his appendectomies at a cost of $381 a pack. Now, this doesn't mean it's right or wrong, but it causes you to look deeper to see if there's a less expensive alternative to use. Next, numerous outpatient procedures, and we see this so much, are being performed while the patients are inpatients, but they have nothing to do with the inpatient stay. These procedures are rarely reimbursed to the hospital, as well as the fact that the outpatient revenue is lost. An example is when a patient comes in for congestive heart failure and they have a slightly lower hemoglobin and hematocrit, and so the attending consults a gastroenterologist who does a full GI workup while the patient's an inpatient rather than scheduling that procedure post-discharge. In addition, gaps in care are often seen where patients wait 2, 3, 4 days to get on the surgery schedule. Now that might be due to a packed OR schedule, but it's also due to not following up in a timely manner to consult the surgeon and/or to complete the workup. Next, consultants not seeing patients for 24, 48 hours after the order is written. And last, we also see wide variation between physicians regarding ICU stays, telemetry days, pharmacy costs, radiology lab, when their patients all have the same severity of illness. And it causes a question on, okay, what are you doing that allows you to do this with less cost than what I'm doing so that we can adjust the care accordingly? I think, finally, one last example are orders that are being written by mid-level providers, and especially at academic medical centers. Residents, consultants, they're implemented and they're changed hours later, and then they're changed again. And we've seen this occur sometimes as often as 3 to 4 times a day with no apparent change in the patient's condition, only changes in orders.
Good examples, Nancy. Dr. Weiss, how important are risk-adjusted analytics in your world?
Well, really, just to piggyback a little bit on what Nancy said, and I think she hit all the points. I mean, they're very, very important. And I think, if you look at, and Nancy touched upon this a little bit, the psyche of most, if not all, physicians, we're very much data-driven, and we also can be, at times, fiercely competitive. So I think sharing risk-adjusted data and either permitting or enlightening folks about whether their patients really are sicker than everybody else's patients can certainly be eye-opening and be a key thing to reducing variation. To sort of maybe just give a little different example, like I said, I think Nancy touched on it so well. We have most of our leadership in data analytics, again, led by our physicians. So our Chief Medical Information Officer, our actual Director of Analytics is an MD, PhD, and those are our folks that regularly interact with our provider teams and demonstrating and sharing the costs of care, outcomes data, our dashboards. And I think as most physicians are hearing now, we're moving away from volume but to value. There is becoming an increased interest in cost of care as well as dashboards. Now, we've built through our analytics dashboards for most of our providers so they can not only see the volume of work that they do, but have a sense of what is my length of stay, what is my choice of antibiotic, and how expensive is a stay with me as it may be with one of my colleagues. We've also really stepped back and looked at, from our data, the number of neuroimaging studies that we are doing, and then looking even further at the indications for those neuroimaging and the appropriateness of our neuroimaging, and really have seen a significant decrease in the amount of neuroimaging that we are doing. So rather than everybody getting the neuroimage, it's really risk-based. So we're really trying the best we can to engage physicians by using the data. And I think it's also important to point out that we looked at, and this is probably where we were maybe too inclusive, as we were initially setting up some data order set sheets, we saw that there are 2 very common tests that were being ordered when patients were to present with chest pain, and that was, some folks ordered a CKMB, some folks ordered a troponin. Now remember, this is an OBGYN talking about chest pain, so bear with me here. But as one of our pathology colleagues noted, that these are really 2 fairly duplicative tests. And as we then, from physician leadership, asked providers, some of them weren't even aware that both of these were on our data set sheets. But because they didn't even look at the other ones, they wanted the troponin, they didn't really care what else was on there. So, we looked at, from data, we looked at not just the number of patients, but the number of tests that were being ordered. And by looking at this, we actually had $1 million savings because we weren't doing all these duplicative orders and changed our order set sheets. So we couldn't have done that without some of the risk-adjusted analytics, nor could we had that from really physicians being the leaders in questioning why things were being ordered.
Great insight. We're going to skip ahead to one of our other questions right now. We've spoken a lot about the work that needs to be done in order to reduce clinical variation. Ensuring your organization is structurally prepared, rallying your physicians, obtaining, synthesizing, and analyzing reams of data. So now the question becomes, how do you prioritize where to begin? Shelley, what are your thoughts?
Well, there's a couple of ways. The first way that we have done it is to look at our top DRGs through utilization and cost. And are we managing our length of stay and any of our outliers, and what are those in pinpoint? But if you really look at the top 10 in your volume and cost and you hit those, you're going to get the bulk of your financial imperative. And it also sets a tone for the other clinical pathways and variations in care. Another way we found is we have some trackers through our emergency department that talk about utilization by physician and some predictive analysis. But when speaking with our physicians, you begin to find out that some of the tests that are ordered are because of the things we have in our electronic medical record. So it includes a bundled test, and it's a default. And so sometimes it means going into finding out what the variation cause is and modifying the process. So in that case, we were having some overutilization because we were standardizing care and we were doing bulk order sets in the lab that were too expensive. And so we're having to go in and modify that default in our electronic medical record. Again, physician engagement is imperative. If you don't have the clinical understanding, again, I can see data all day, but without that physician's input, I wouldn't know what the driver was for that cost on those tests. And I wouldn't be able to change anything. You have to have a physician champion who believes in the best patient care and that pathway and that standardization of care is providing the best quality care, or they're not going to support it. So I really believe that it's starting with your high cost and high volume DRGs and in your outpatient setting as well, and then getting those physicians to partner with you to really drill in and find the problems.
Dr. Weiss?
Agree completely. Well, I agree completely, and I think continuing to have that conversation as we move from value over volume, our providers are really recognizing that the outcomes are paramount to our success, and decreasing the variation is certainly key to that as well. I think we have to be real and say, gosh, certainly one could be overwhelmed by the 350 or so metrics of and value-based purchasing. So you do need to rank order them, and we rank order them. And you heard example of DRGs, and we similarly, but we do it based on our own organizational results, including losses and bonuses, but also ones that we think we really can impact and change. You can't overnight impact and change all 350 of them, but we try to identify the ones that we think we can. We have physician buy-in. So, for example, we may tackle readmission, we may tackle CAUTIs, we may tackle CLABSIs. Just to give an example, and we involve the docs in this, but we also tie some of our physician performance and payments to these initiatives. So we try to get buy-in in helping to sell it, but we also do incentivize our physicians to improve these initiatives and reduce our clinical variation.
Thank you. Stephen, as CEO, you've talked a lot about your resources and tools, but what key metrics and other insight do you use to gauge your organization's progress in reducing variation?
Well, I think a lot of, there are really three dimensions that we try and focus on. One is quality of care, and we talk a lot about that, cost of care, and then patient satisfaction or patients' engagement in their own care. Now, examples for quality of care key metrics might be reduction in readmissions, reduction in ED usage, direct impact, for example, of using our own affiliated home care agencies. That, as an aside, we've really found that we can reduce length of stay and reduce the rate of readmission by really focusing our home care agency, working with our teams. And that actually has had a multi-million-dollar impact. From cost reduction perspective, we really track our internal costs as well as our overall CMS payments for the episode of care. And one example for patient satisfaction is reaching a target of 0 complaints from patients and families, as well as reducing ED visits following within our bundles. So we track all of these regularly and share that information regularly with our care team. The ability really to combine cost and claims information together with clinical data has really been very key for us. And we're still working on creating an enterprise data warehouse that would allow us to bring together the data from multiple sources and use our dashboards and other population health management tools to share with the providers. A real key functionality for our provider perspective is being able to identify measures that need to be addressed, and then being able to drill down for what a patient may particularly need, and then being able to use our medical record. We happen to be on the Epic system to identify which patients may need, for example, diabetic eye exams, and being able to order that so we can really start focusing on population issues. The ability to use the data that we have for population health is really becoming a key point.
Thank you, Stephen. You know, we're getting close to, we want to save time for some questions and answers. So Nancy, you know, could you give us some idea of some other key metrics and resources and tools that you recommend?
Well, I'm going to try to just add to what's already been said. I think Stephen covered a lot of those, as well as earlier presenters. So I guess I would just add that it's critically important to be focused and not to select too many metrics to review, so that the organization really can ensure that they're monitoring and using those metrics. We also find that that the indicators will vary and should be individualized for each hospital based on their efforts and their practice culture. So one size doesn't fit all. It's also important to build organization-specific metrics relative to the change efforts that are going on. So they might be, for instance, are you looking at, is clinical variation actually being reduced where you have put change efforts in place? Are physician and mid-levels using the order sets and protocols? Are patients progressing to the plan of care, the clinical pathway? Stephen's already mentioned length of stay, excess days, per service line, per physician, reduction of utilization components, so the resources. So I guess I would just say, and we've already talked about physician scorecards, but I guess I would also add, while it isn't a metric or a resource, a tool, in order to truly reduce clinical variation, accountability across the organization at all levels for all individuals is also critical. So it's probably more of an approach that's important to this work.
Thank you, Nancy. Panelists, you've led us through a great discussion on clinical variation. As we've heard, reducing acute care clinical variation has a very real and significant impact, not only on quality, but on the bottom line. Engaging physicians truly is the key to reducing variation. Monitoring the right data and accountabilities are essential to assuring sustainability. The urgency to reduce clinical variation has never been greater. We want to challenge our audience to consider what their immediate call to action will be after today's discussion. Panelists, thank you again for an incredibly insightful discussion. We're now going to open the floor to the audience and any questions they might have for us.
Yes, thank you. Let me go, Donna, in saying thank you to all of our panelists for that fantastic presentation. As she mentioned, we will now begin the question and answer session of the webinar. You can submit any questions you have for our panel by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We have gotten a lot of great questions in so far. The first question we have can probably be tackled by Patrice first. It is, what do you do when a physician or group of physicians resist the idea of studying and addressing variation?
Well, so I guess I would approach it two different ways. The first one is, are they aware of what the standards of care really are, and why are they in variation? And oftentimes that can be the first key. Now, who delivers that message to them, I think, is very important. Is it a hospital administrator? Is it via a cold email, or is it one of their respected peers, either the chair of the department, their chief of the service? But I think they really need a detailed explanation of what their variation is and why it is a variation. That doesn't necessarily mean at that point say, okay, I'm going to change. Then I think they need to be educated on, and what does this variation mean to the patient? All of us who went into medicine because we want to help patients and we don't want to do harm. So we always put it back on what does this variation mean to the patient? If their variation does not have a difference in clinical outcomes, but their variation has a difference in costs and expenditures, that then down the road could have an effect on patients and the ability to deliver care if resources become an issue. I think the other piece that I think sometimes is very helpful, and this is really one of the keys of a high-performing group, is when you have completely unblinded data, and data is put up there in whether it be departmental meetings, section meetings, OR committee meetings, quality meetings. I think at some point you've got to unblind the data, and people need to be held publicly accountable for their variation. In some ways, it may be a little bit easier for us, or for me as a chief medical officer working with the chair, if it's a physician with whom we employ. But we also have 30% of our medical staff is not employed. So a lot of times it's engaging them, educating them, telling them what it can mean for their patient, what it can mean to future resources, and eventually, an example would be, as we did the orthopedic redesign of devices. I mean, not everyone was so happy if the 4 that were chosen was not their favorite one. But sometimes just those tough decisions do need to be made.
Great, thank you so much for that insight. The next, does anyone else on the panel would like to chime in on that question? Okay, hearing no one, we can move on to the next question from our audience, which I will direct to Shelley first. Shelley, are you seeing opportunities to reward clinicians financially for reducing costs?
Yes, we are. We actually have part of our incentive program for both our directors and executives also is our integrated physicians are included in that. And we do have incentive payments annually based on clinical, quality, financial, and improvement metrics. And it's varying percentages for each of those. And I find that it helps with engagement, especially when you're adopting new processes. It helps with early on engagement. It helps them have a little more ownership in the process instead of, administrative driven to physicians on change and standardization. But I also find that most physicians are also very interested in the financial outcome of the organization, and again, partnering with them is just the best way to do it.
Perfect. Thank you so much, Shelley. Patrice, I know you mentioned it during an answer during the presentation. Would you have anything to add on incentivizing clinicians financially?
We clearly do. I think Shelley described it well, but part of our scorecard, we have a clinic scorecard, there are department scorecards, and then there are section scorecards. And it's really based on the Quest model of quality, engagement, patient satisfaction, safety, transparency. And I would take it even a step further, where one of the clinic scorecard metrics may be something related to how is a patient with an acute myocardial infarction initially handled or treated if they come into the emergency department. Well, several several groups of physicians could say, wait a minute, I have nothing to do with that. I'm not a doctor who's going to be called to see that patient. But that instills even further on the clinic scorecard the concept of we are one system together, we are one clinic together, and that no one cog in the wheel can function by itself. So, and then we tie that to a percentage of what a potential bonus could be. So we not only try to tie it to the individual and the section or their department, but tie those incentives to the overall operation and function of what metrics may be very important to the organization. So it could be readmission rate, it could be surgical site infection, it could be catheter-associated urinary tract infection. A psychiatrist could say, well, wait a minute, what do I have to do to affect that? Well, it builds the concept of we're all in this together.
Great. That was very helpful for us to understand, I think. Stephen, the next question can be directed towards you as CEO of Strong Memorial. Where is reducing clinical variation on your priority list?
Well, it's, as I've mentioned a number of times, it is, frankly, right up there on the top as we move to value. The only way we can really achieve any success as an organization is to manage what it is we do. And I certainly agree with all of the panelists' comments, particularly Dr. Weiss in talking about transparency, sharing data, actually having physicians get a chance to really compare their data with others, and then participating in whether it's gain sharing or other kinds of approaches. And we just recently renovated our compensation plans to really account for all of this. So it really ties to the institutional goals, in our case as an academic medical center, both clinical education and research, of being a successful organization. And obviously our faculty are the main reason why we really are, and we really have to focus on making sure that they understand how patients are being taken care of. They get a chance to input on how it can be improved, and they really have a chance to have some control over the process in what are very complex institutions, including multi-institutions as patients move across a continuum.
Great, thank you so much, Stephen. I think we have time for one more question. I will direct this one towards Nancy. How do you get the system and management team to cohesively and collaboratively support clinical variation of project and best care teams? The teams can create great guidelines and pathways that have been piloted successfully, but they are not empowered to change the system.
I think that goes back probably to the accountability issue, but also transparency and integration of the full team across the organization. Clinical redesign is far more complex, I think, than traditional performance improvement. And so the changes are transformational to both the practice and the entire culture of the organization. And so it really requires all disciplines to be involved, to bring their best thinking, but also to have people on the team who aren't clinicians, such as IT and supply chain, et cetera, so that you can look at all aspects of that care and integrate that into the processes. One COO recently said to us, he said, I knew that this would be a lot of work. I didn't know it would be this hard. And so the amount of tenacity and rigor that it takes for the team, and I think giving them the support that they need, sometimes that's just extra staff to support the efforts. Sometimes it is leadership support to remove the barriers. The effort really does require full engagement by top leadership to support the physicians and the staff as they transform that care. And as Patrice said, to support the CMO as they're really driving that practice that sometimes physicians don't adopt right away, and it takes a variety of different efforts or initiatives or approaches in order to be able to try to reduce the variation. So today, patients shouldn't be in the hospital 1 minute longer than necessary, and so the team really needs to ensure that the patient has the support outside the hospital as well. And I think that our transformation is looking at episodic care delivery that we're redesigning so that we can focus on patient outcomes across the continuum.
Great. Thank you so much, Nancy. I think that's a great question to close on. That's all the time we have for today. I want to thank our panelists for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.